Good day. Today I would be taking a short lecture on recognizing primary immune deficiency disorders in pediatric practices. The host immune defense, as we know, has non-specific or innate immunity through barriers in the skin, secretions, mucus, tears, saliva, mucociliary clearance, and peristalsis. Then there are phagocytes, which could be neutrophils and macrophages, complements and cytokines. There are specific adaptive humoral B immunity through B lymphocytes and cellular through the T lymphocytes. Now here, if you see how the humoral and the cell-mediated immunities work, in the first column is the humoral immunity. When extracellular microbes come, the B lymphocytes get stimulated, antibodies are secreted, and they block infection and eliminate extracellular microbes. Now you see the cell-mediated immunity. Phagocytosed microbes in the macrophages are presented to T helper cells. The T helper cells adhere to this macrophage, and the activated macrophage kills the phagocytosed microbes. Then in the third column is intracellular microbes such as viruses replicating within the infected cell. The cytotoxic T lymphocytes adhere to the cells and kill the infected cell and eliminate the reservoir of infection. Same here is the response, the serum antibody titers on the y-axis, and on the x-axis is weeks after the infection or presentation of the antigen. You have the naive B cell, then you have anti-BX, anti-B cell, anti-Y B cell. When there is a exposure to X antigen, there's primary X response. When there is exposure to Y and X antigen, the memory B cells get stimulated and they have secondary anti-X response, whereas naive B cells get stimulated to give the primary Y response. Now, immunodeficiency represents a diverse group of abnormalities of immune system resulting primarily in increased susceptibility to infection. It could be primary, congenital, inherited, or secondary, acquired, could be transient or permanent. Now, the primary immune deficiencies overall, the clinical significance incidence is thought to be 1 in 2000. 50% are due to antibody defects, 20% combined, 10% cellular, 18% phagocytic defect, and 2% complement defect. So when should we suspect PID? When there is severe infection like meningitis, peritonsillar abscess, osteomyelitis, severe pneumonia requiring IV antibiotic, especially when it's recurrent or refractory. P is persistent infection not improving despite antibiotic therapy. Unexplained oral thrush persisting beyond 1 year of life. Persistent diarrhea. Recurrent infections like frequent middle ear infection more than 8 per year, more than 1 serious sinus infection per year, and more than 1 pneumonia per year. U is unusual organism, opportunistic organism, and E is early onset autoimmune disease or malignancy. So the acronym is SPRU. What are the warning signs? Here is a picture of what all you should suspect PID when 4 or more new middle ear infections in 1 year, 2 or more serious sinus infection in 1 year, 2 or more months of antibiotic with little effect, 2 or more pneumonias within 1 year. Then it could be failure of infant to gain weight or grow normally. Could be recurrent deep skin or organ abscess, persistent thrush in the mouth or fungal infection of the skin, need for intravenous antibiotic to clear infection, 2 or more deep-seated infection including septicemia, and a family history of primary immune deficiency. So what does the literature say? More than two warning signs, which of the 10 I told you, has a sensitivity of 94% and specificity of 64% for diagnosing PID. This was estimated in a retrospective analysis of medical records of 204 patients with PID in Egypt. Now, the types and clinical predictors of PID in a publication in 2019 by Gupta et al. Out of 528 suspected cases based on those 10 symptoms which I told you, 120 had proven PID, which is 23%. Humoral and cellular immune deficiency was present in 92%, phagocytic defect in 29%, antibody deficiency in 18%, innate immunity and dysregulation 17%, and other well-defined syndromes in 7%. The frequency and distribution of warning signs in immune deficiency disorder related PID were family history in 23%, consanguineous marriage in 8%, previous SIP death in 23%. However, it's noteworthy to note that there was delay of 5 years in the diagnosis. Now, in another study published earlier in 2008, the frequency of features in a retrospective cohort of 27 diagnosed cases of PID. There were deep-seated abscess in 35%, extensive fungal infection in 4%, disseminated CMV in 4%, recurrent persistent diarrhea in around 37%, recurrent persistent pneumonia in 70%, disseminated TB in 7%, disseminated BCG in 4%, otitis media in 4%, and family history of sibling death in 7%. So, specific immune deficiencies affecting different lines of immune system. Complement deficiencies, we have the early classical pathway, that is 1, 4, 2, and 3. It manifests as pyogenic infection, lupus-like disease, and vasculitis. And the late components of complement are C5 to 9, with recurrent or disseminated neiserial infection. Phagocytic defects, disorders of neutrophil, cyclic neutropenia or severe congenital neutropenia, disorders of adhesion like leukocyte adhesion defect, disorders of chemotaxis like Shediac-Higashi syndrome. They also have abnormal intracellular killing, disorders of intracellular killing like chronic granulomatous disease. Now, chronic granulomatous disease is a defect in the NADPH oxidase enzyme system, leading to failure of production of oxygen radical and hydrogen peroxide, which leads to inability of intracellular killing of mostly catalase positive bacteria and fungi. Manifests with recurrent pneumonia or deep-seated abscess due to staph, serratia, bacillus, cepacia, aspergillus, and other organisms. Can be inherited as X-linked or autosomal recessive. It is diagnosed by NBT or oxidative burst assay, and patients can be put on Bactrim and itraconazole prophylaxis. Bone marrow transplant is recommended in some of the patients. Now, deficiencies in T immunity characteristic. Patients are below 5 months of age, usually associated with recurrent infection with fungal, viral, or microbacterial pathogens. Patients may develop infection with opportunistic organism, that is Pneumocystis jirovecii, failure to thrive, and chronic graft versus host disease may develop secondary to blood product transfusion or intra-utero from maternal-fetal transfusion, often associated with B cell defects because of lack of T cell help. Deficiencies in T cell immunity causes could be acquired, like severe malnutrition, immune suppressive drug, radiation, HIV, or it could be congenital, as in cases of severe combined immune deficiency syndromes, usually characterized by marked lymphopenia and very early presentation In the first few months of infancy, lymphopenia less than 2000 per microliter in a healthy neonate in a, as, as an indication for further investigation. It's a pediatric emergency, and the success rate of stem cell transplant, if done before 3.5 months, is very high before infections develop, and it's less than 80% success rate after infection has developed. Newborn screening for SCID. Since early detection and early BMT for patients with SCID is critical, a newborn screening was developed. The screening is based on the detection of T cell receptor excision circles by PCR, which indicate production of naive T cell from the thymus. D cell deficiency causes could be combined immune deficiency, T cell not very severely deficient, more than 300 per microliter, and presentation may be less severe, for example, in Wiskott-Aldrich syndrome, ataxia telangiectasia, or DGeorge, and there are many others. DGeorge, the features are congenital cardiac malformation involving large vessels, hyperplastic thymus, parathyroid deficiency, velopharyngeal insufficiency, cleft palate, dysmorphic features, results from defect in the embryonic development of third and fourth pharyngeal arches. Most patients have microdeletion affecting 22q11. Most patients have normal T cell number and function, and most of those with lymphopenia recover by the end of their first year. This is the picture of a patient with DGeorge syndrome. Wiskott-Aldrich, it's X-linked disease characterized by eczema, thrombocytopenia with small platelets and immune deficiency. Patients' lymphocyte proliferation is depressed. They may have variable antibody abnormalities, and it is treated by BMT. Now, ataxia telangiectasia is autosomal recessive. Progressive cerebellar degeneration is there. Cutaneous or ocular telangiectasias are there. Immune deficiency affecting predominantly cellular immunity and T and B cell is there. There's sensitivity to ionizing radiation, high incidence of malignancy. The basic problem is in DNA repair, and patients have elevated alpha-fetoprotein. This is a patient of telangiectasia having telangiectasia in the sclera. Deficiencies of B cell immunity, clinical characteristic, onset, usually after 7 to 9 months, recurrent infection with encapsulated organism. Patients usually develop chronic or recurrent sinusitis, otitis media, pneumonia. They also develop recurrent sepsis, meningitis, or osteomyelitis. Few problems with fungal or viral infections except with entero and poliovirus, and there's little growth failure. Now, the major causes of B cell immunity deficiencies are X-linked A gamma globulinemia, autosomal recessive A gamma globulinemia, common variable immune deficiency, hypogammaglobulinemia with poor antibody response, hyper IgM syndrome, high normal IgM, and with high and IgA syndromes. The clinical approach to patients with suspected immune deficiency. First, history. Usually, the earlier the onset, more likely to be severe immune deficiency. For example, SCID usually presents in the first 4 to 5 months of life. A gamma globulinemia usually presents 7 to 9 months of life, and the family history is important. Site of infection. Involvement of specific sites is likely more common with specific types of immune deficiency than others. For example, recurrent gingival and skin abscess in phagocytic defects, recurrent sinopulmonary infection in B cell defect, recurrent meningitis in complement defects, and chronic diarrhea should always raise the possibility of immune deficiency. The nature of infecting organism may indicate the type of deficiency. Now, the type of infective organism. Recurrent viral, fungal, mycobacterial, or opportunistic infections such as T cell defect. Recurrent infection with invasive encapsulated bacteria like pneumococcus suggests B cell defect, and recurrent infection with bacteria of low virulence such as staph suggests a neutrophil abnormality. Recurrent Neisseria would suggest complement effect. History of adverse reaction to vaccine. Live attenuated vaccines may cause disease in immune deficient patients. For example, oral polio may cause paralysis in patients with SCID or hypogammaglobulinemia if he receives the vaccine or is exposed through vaccinated children who are sharing the live attenuated virus in this too. So these are the 10 warning signs I had showed you earlier just for your recap. On physical examination, absent tonsils suggests B cell defect, absent lymph nodes T or B cell defect, lymph node hyperplasia, combined variable immune deficiency or chronic granulomatous disease, absent BCG scar T cell defect, delayed separation of umbilical cord, leukocyte adhesion defects, and there are others. So how would you assess the immune system? Stage 1 is general non-specific evaluation, the CBC, differential and counts and blood film examination, quantitative immunoglobulin level estimation, and in newborns for chest X-ray for thymic shadow. This is a chest X-ray of a newborn, and you don't see a thymic shadow here. Stage 2 evaluation is based on suspected type of immune deficiency. If it's innate, then you see phagocytic function study, NBT or oxidative burst, CD50, AH50 is level estimation, flow cytometry for adhesion molecules, and tests for chemotaxis. Specific immunities for humoral component, specific antibody response to tetanus, Haemophilus influenza and pneumococcus vaccines, isohemagglutinin levels, IgG subclass antibody levels. And for cellular component, lymphocyte subsets like CD3, 4, 8, 19, 16, 56, delayed skin hypersensitivity reaction to intradermal candida or tetanus, not sensitive with limited availability, lymphocyte proliferation assays in vitro, and HIV testing. And in stage 3, more detail like next-gen sequencing may be required to find the genetic problems in the patient. Now, here is a case study. An 8-month-old boy was presented to a pediatrician with fever, lethargy, left ocular and facial paralysis, as you can see, flaccid paralysis of lower limbs. CSF showed picture of aseptic meningitis. 2 months later, the child had received oral polio immunization. A presumptive diagnosis of post-infectious polyneuritis was made. What should be done next? Serum IgG levels were done and the concentration were very low, 9 mg per deciliter. Infant was referred to a pediatric allergic immunologist. Mature B cells were absent from circulation. T cell immunity was normal. Spinal fluid subsequently grew vaccine strain of poliovirus. Based on absence of mature B cell in the circulation and a state of pan-hypogammaglobulinemia, a diagnosis of agammaglobulinemia was made. The child has done well on monthly intravenous immunoglobulin replacement therapy but is still hemiplegic. Individuals with primary immune deficiency should not be given live vaccines. This is another study. A 4-month-old infant was noted to have persistent oral thrush due to Candida albicans. A consulting immunologist ordered a barium swallow X-ray and ulcer craters due to the same organism observed throughout the esophagus. Where could be the defect? What to do next? The child's serum IgG was low, but IgA and IgM levels were virtually absent. Few mature T cells could be detected by flow cytometry, but there was no response of peripheral lymphocytes to stimulation by mitogens. A diagnosis of SCID was made based on very low T cell number and their suppressed function. The child survived with BMT transformed his HLA compatible sister. Now, what is the role of IVIG in PID? IVIG is purified human IgG prepared from pooled plasma of thousands of donors. Mechanism of action: it is estimated that an IVIG preparation contains 10 million antibody specificities. This leads to neutralization of viruses, opsonization of bacteria, and neutralization of. So, the indications of IVIG in PID are A gamma globulinemia, CVID, CID. Dosage: it is recommended to maintain a trough of IgG above the lower limit of normal, and infusion is given 3 to 4 weeks interval, may be shorter. Monitoring IgG trough level is done every 3 to 6 months. Now, the adverse effects, non-specific generalized reactions are usually reported in 1 to 10% patients. They are mostly mild, such as flushing, headache, backache, chills, myalgia, nausea, and the intervention is slow infusion and treat the symptoms. Moderate, like urticaria, bronchospasm, vomiting, intervention is stop infusion and treat symptoms. Severe, like anaphylaxis, anaphylactoid, intervention is stop infusion and resuscitate. This is very rare. It may be because of IgG or IgE or anti-IgA antibodies in the infusion. Then they could organ specific and idiosyncratic reactions are rare, and there is a risk of transmission of disease. Thank you very much for your kindness.